it is officially noon according to my iPhone here. So I'll go ahead. It is a great pleasure to introduce Dr. Yi Bates. I'm going to give you a brief bio. She was born in southern China and grew up in a suburb of LA in California, and later moved to Mobile, Alabama with her family. She went to UCLA for undergrad and the University of South Alabama for medical school, and did her adult psychiatry training at the University of Florida, and is currently a second-year child psychiatry fellow here at UCSF. Aside from talking to super cute kids and being a mom to her own cute 1-year-old, she enjoys hiking, reading frivolous novels, I'm with you, sister, and writing fiction and cooking and watching completely non-educational mindless TV and exploring all the cool little neighborhoods in the Bay Area, absolutely fully masked and sanitized, of course. These are Dr. Yi Bates' words. So it is a pleasure. I so enjoyed reading that bio. Thank you that's a gift to me. So thank you. Without further ado, let's give a warm welcome to Dr. Yi Bates.
Yay. Thank you so much, Dr. Stewart, for that. I appreciate it. Hello, everyone. I'm so grateful for the opportunity to speak today, and thank you all so much for joining me. In this next hour, I'm going to talk about anti-NMDA receptor encephalitis. It's a topic that's always been really fascinating to me, but prior to my time at UCSF, it was a bit of a unicorn in the sense that we've all heard of it, but no one's actually seen a confirmed case of it. And then I started my first rotation at UCSF, which is consults at Beecher with Dr. Graham here. And lo and behold, we had not one, but 2 cases in a row, one with me and one with the fellow after me. So I thought I would take this opportunity to talk about how a real life case looks like, and then I'm going to expand upon that a little bit and talk more about anti-NMDA receptor encephalitis and how we as mental health professionals can spot these cases. So just a little overview about how this talk will be structured. I'm going to start with a case in popular culture, then I'm going to move on to my case presentation, then a little bit more about anti-NMDA receptor encephalitis and the pathogenesis, clinical course, diagnosis and treatment. And here, Dr. Graham, who is my attending at Beecher for this case, and who is also our discussant today, she will talk more about the role of psychotropics in anti-NMDA receptor encephalitis. And then I'll very briefly go over prognosis and recovery. And then hopefully, if time allows, we will talk about something that really came up in this case for me, but it's just a really important topic for us as mental health professionals. That is how to talk to patients and families of going through an acute illness, especially when there's psychosis and agitation involved, which adds just another level of stress and anxiety and urgency. So by a show of thumbs up, has anyone heard of this book or movie? Any chance? Yay, okay, great. So some of you have, that's awesome. So this topic has actually made its way into a few books and movies, the most famous of which was this book written by a journalist named Susanna Collin. She had anti-NMDA receptor encephalitis, and this was turned into a Netflix movie. So here is a video of Susanna Collin talking about her experience with this illness. So the video itself, it's a little dramatic, but I think it's pretty effective in describing what it's like to live through this illness and recover from it, both from a symptomology standpoint and emotionally, like what it's like to have your life turned completely upside down and then having to rebuild yourself again. So here's the video.
It all started with when I thought I had a case of bed bugs, and said, you don't have bed bugs. Then after that, I was feeling very tired and lethargic, and really, I just didn't want to go to work. I felt not like myself. And then I started having numbness in my hands and my feet. And at that point, I went to a neurologist who first diagnosed me with mono. After that, I started acting paranoid. I had hallucinations, and then I had a seizure. Because I literally don't remember the good part of the month that I was in the hospital, I had to rely on medical records, interviews with doctors, interviews with my family, interviews with my boyfriend. You know, pretty much I had to just recreate that time using the skills of a journalist. there's video that exists of me in the hospital. And when I watch it, it's very much, I'm watching this other Susanna, this other person is so far divorced from who I am now. I mean, she's frightened, she's angry, she's just terrifying. And in a lot of ways, I've been trying to reconcile who that person was with who I am now, and what part of me is this kind of monstrous person. And through the course of researching this, I've come a little bit closer to understanding that other Susanna, but she's always a stranger. She's someone who I have to dig really deep outside of myself to really understand. I have to ask other people. I have to read pages of medical records to get anywhere close to understanding who that person was. Towards the end, I stopped being paranoid, and I stopped having these unbelievable hallucinations, and I was becoming catatonic. I just had I hardly moved. I had no emotional register. I just kind of stared off into space. I had very rigid movement. And basically, now I know, looking back then after my research, that I was heading towards what would most likely have been a coma, and for some people, death. I was ultimately diagnosed by Dr. Weill at NYU. He was the first doctor to really sit down and see the whole picture, the bed bugs, the paranoia, the hallucination, the catatonic state. He also noticed I had high blood pressure. At one point when he visited me for the first time, he did something that no other doctor asked me to do. He asked me to draw a clock. And it's a very simple procedure. I had gone through $1 million worth of blood tests, MRIs. This is one clear step that he asked me that cost nothing. Basically, he asked me to, he gave me a piece of paper and asked me to draw in 1 through 12. And I drew every single one of those numbers on the right-hand side, which showed that I had inflammation in the right side of my brain. After a brain biopsy and a spinal tap, they ultimately diagnosed me with what is called Anti-NMDA Receptor Autoimmune Encephalitis, which is, in short, when your body's immune system attacks the brain. The hardest part for me was the recovery, and it was the hardest part to write as well. At that point, I had lost my identity, who I was. Everything about my personality was just gone, and I had to rebuild that from scratch. I'm reminded of the scar I have from my brain biopsy on my head, and I know I'll never be the same person that I was before. And I think it's given me such purpose in my life, because I feel like this story and living through this horrible time has given me, the strength to help other people and the ability to help other people, which I think is the most wonderful gift of the whole thing.
Oops. All right. So moving from this very short synopsis to a slightly longer, but hopefully just as engrossing case presentation of this illness. This is a patient I saw on Beecher Consults about a year ago. It's a 13-year-old male who was transferred to the hospital from an outside hospital for evaluation of new onset seizures. He had no significant medical history except for some mild speech delay, no significant psych history, except for a vague description of an anxious temperament. In the months leading up to his hospitalization, his anxiety worsened significantly, especially relating to food and swallowing. So he'd watched a video about throat anatomy at school, and he became convinced he couldn't swallow despite being able to, and consequently he lost like close to 50 pounds. He also became very paranoid about strangers staring at him. And in the weeks leading up to his hospitalization, he started displaying bizarre, unexplained behaviors. Like once he started just screaming inconsolably and couldn't articulate to his parents why. Another time he couldn't sleep at night at all because he was seeing green goo on the ceiling. And every time he would have no recollection of this the next day. He had 3 seizure-like episodes, so each time he was taken to the ED by his parents, and he was sent home after his workup was negative. And so the day of the hospitalization, he actually had another seizure-like episode and lost consciousness and remained post-ictal in the ED. So then he was transferred to the Beecher ED for further evaluation. In the Beecher ED, he was like very tense. He was pacing around. He was making eye contact, but just not speaking to anyone. And then he would just promptly fall asleep. So EEG, MRI, and LP were ordered for the next day. He was admitted to general peds with neurology following, and we were consulted for agitation med recs and medication recommendations for MRI. When I interviewed this patient, he was engaged in conversation intermittently, and he would answer questions actually really appropriately and then he would just promptly forget what he said altogether. So for example, he told us very clearly he was in the 8th grade and what school he went to. But later in the conversation, when school was mentioned again, he turned to his dad and would ask, "Hey dad, what grade am I in again?" So he did a lot of this kind of fact checking with dad, like almost like a dementia patient. He did report having visual hallucinations. The circumstances around his hallucinations were not very clear. The evening before I saw him, he actually pulled out his IV and said some really odd things. And then that morning, he bit off his bandage, voiced that he was going to die, voiced hallucinations, and attempted to leave. And when we asked him about it, he didn't remember any of it. He couldn't remember why he pulled out his IV. He actually denied feeling paranoid at all. And we got to observe a nurse placing the IV like in the room with him. And he just kept going back to touch where his nurse was placing the IV when she was doing it. And we would tell him, "No, don't do that. It's important you don't touch that." And he'd listen, and you pull his hand away, okay. And a second later, he'd go right back over again. Like he instantaneously just forgot. And then we'd tell him again, he'll pull his hand away. So it was just like back and forth the whole time. And meanwhile, he was completely calm and not agitated at all. Because of the nature of his psychosis and ultrasensorium, there was a wide differential. So just very briefly, here are his vitals and diagnostic tests. So first, his vitals, they were largely normal. He had intermittent tachycardia and elevated blood pressures, but it was like pretty nonspecific because he was also intermittently agitated. Head CT was normal. MRI was normal. The CSF panel showed mild pleocytosis with a white count of 12 and 100% lymphocytes, but otherwise normal. So they were considering it maybe like a viral encephalitis for a while. EEG was normal. Interestingly enough, plasma came back during the first series of tests, so they were considering Wilson's disease for a bit, but there was no transaminitis, and 24-hour urine copper collection was normal. And then, of course, as you might have guessed by the title of this talk, the anti-NMDA receptor antibodies were positive in both the CSF and serum. And once they found that out, they did like full body scans to look for any tumors, and they were all normal. So psychotropics, for the sake of time, I'm going to keep this really brief because Dr. Graham will lead a more detailed discussion of this later. We initially recommended Zyprexa-Zydus PRN for agitation with IM backup, but later we scheduled the Zydus nightly because he became increasingly anxious and he wasn't able to sleep. Once the diagnosis was confirmed, though, we swapped the Zyprexa to Seroquel due to the preference of low potency, low D2 binding antipsychotic and NMDA receptor encephalitis. We also added clonidine for sleep at night and Ativan IBIM for agitation if he couldn't tolerate the PO. The psychologist in our team also spoke to the primary team about ways of supporting the patient by first identifying his triggers. So these are like physical discomforts like IVs, needle sticks, being left alone without dad, and then finding prevention and management strategies for these outbursts. And these include ensuring that he's prepared for procedures like vitals and blood draws. So for example, before you do a procedure, you can prompt him by simply stating, "Now I'm gonna do XYZ," like really explicitly. And of course, not speaking about his illness in front of him. So like pulling dad out of the room to discuss matters related to him. And then reassuring, reorienting, limiting staff changes, minimizing the amount of providers in the room. And if all that fails, utilizing a posy bed or a veil bed like this, which is essentially kind of like a pack and play with an enclosure on top. This is so we can avoid like tide restraints and IM medications all the time, so we can keep him safe. Meanwhile, the primary team started him on immunomodulating treatment along with seizure medications. I won't go into this for the sake of time because our role in this part of treatment is very limited, but here they are. So prior to his immunomodulating therapy, he continued to be intermittently confused, anxious, and agitated. He required multiple PRNs, including some IMs, and he had to have some tight restraints for a while. About 2.5 weeks into his hospital stay, which is 1.5 weeks into his immunomodulating treatment and the Seroquel, his confusion had improved, but his memory was still foggy. His hallucination was much rarer. He didn't appear like outwardly internally stimulated. He was conversing with his family as they came to visit. He was playing Uno with them. He would report it. He was feeling better. He was motivated to start school again. Dad felt like he was much more like himself, although he still occasionally had like a distant and unfocused affect. About 3 weeks and 2 days into his hospital stay, he was discharged. We recommended to continue the Seroquel regimen until all his immunomodulating treatments were complete, since the psychiatric manifestations often takes weeks to several months to completely resolve. And we outlined like a Seroquel taper for outpatient follow-up. So finally, where's our patient now, 1 year later? So full disclosure, I haven't seen or spoken to this patient since, so this is all from chart review. He's had no new seizures since his discharge. His Keppra was continued outpatient and then tapered off. He has had no behavioral changes or evidence of psychosis since discharge. Seroquel was tapered off successfully outpatient. His anxiety continued to be an issue. Although it's improved significantly, he gained all his weight back. He was started on Lexapro by his pediatrician. His memory issue still persisted. And he is actually currently in the middle of a neuropsych evaluation for this specifically. So in short, he isn't completely back to baseline, but none of the acute symptoms that brought him to the hospital, like his seizures, hallucinations, ultrasensorium, none of that has reoccurred. So that's a positive. All right, so let's talk about anti-NMDA receptor encephalitis. So first, why are we talking about this? I know this may be considered maybe a dry topic to some of you because not all of us will be necessarily directly treating it, but I feel that it's important to know the basics of this because it's really common in terms of known causes of encephalitis. So and also especially in the young, child psychiatry, child psychology, I think this is really pertinent too. In the California Encephalitis Project, 65% of patients who had anti-NMDA receptor encephalitis were under 19 years old. And there was another lit review of over 706 cases that determined the mean age was 22.6. So a little higher here, but still very young. And also keeping in mind, this is around when we see first break psychosis as well. Psychiatric symptoms are both the most common and the first symptoms to show up. So because of this, these patients are often referred to psychologists or psychiatrists before seeing a neurologist or any other doctor. So we as mental health professionals become essentially the ones that screen for this. At least 75% of patients will have a substantial recovery. So this is very treatable. The rate and degree of recovery appear to be related to how quickly a diagnosis is made and treatment is begun. So it is relatively common and treatable, and the time to diagnosis and treatment has a significant impact on patient recovery and final outcome. So it's so important for us as screening clinicians to be able to recognize when there may be a case of anti-NMDA receptor encephalitis. So we can either order the appropriate tests or refer the patient to the appropriate doctors. It is especially important for prescribing physicians to keep this in mind because often these patients present with psychiatric symptoms first and then autonomic and neurologic symptoms. So let's say a patient presents with psychotic symptoms, right? And anti-NMDA receptor encephalitis isn't considered. So the patient started on an antipsychotic. And then they start presenting with altered mental status, rigidity, autonomic symptoms. So suddenly this is looking a lot like neuroleptic malignant syndrome, right? And that can lead you down a completely erroneous road of diagnosis and treatment. And meanwhile, the underlying condition is like buried further down in the differential, it's left untreated, and the prognosis just continues to worsen for the patient. So long story short, high index of suspicion is key. So just a little background, a little historical context. In 2005, 4 young women with ovarian teratomas reported a bizarre syndrome of severe neuropsych symptoms, seizures, loss of consciousness, and central hypoventilation. 3 patients recovered with treatment of the tumor and immunosuppression, and 1 died of this disorder. This is before anyone knew anything about anti-NMDA receptor encephalitis. The paper that published these cases made some key conclusions. Most of them are pretty spot on. It said, In young women with acute psychiatric symptoms, seizures, and central hypoventilation, a paraneoplastic immune-mediated syndrome should be considered. Recognition of this disorder is important because despite the severity of the symptoms, the patients usually recover. The location and function of the isolated antigen suggests that the disorder is directly mediated by antibodies. And then 2 years later, a team of neurologists and researchers at UPenn discovered the antibody, and anti-NMDA receptor encephalitis became a recognized autoimmune inflammatory syndrome. So it wasn't until 2007 that this was discovered. So it's relatively recent. Today, about 1 in 1.5 million people are affected per year. So it's still rare, but it's not insignificant. This graphic is showing the California Encephalitis Project that we mentioned earlier. Of the encephalitis that had a known identifiable etiology, about 40% of them were caused by anti-NMDA receptor encephalitis. So it's pretty significant, a contributor. So now that we know that this is important, I just want to take a step back and look at things a little bit more globally. There are many, many causes of encephalitis, the majority of which is actually unknown. So that's something to keep in mind, that we're still talking about a very, very small fraction of encephalitis patients. For the encephalitis that have a known cause, autoimmune encephalitis is just a subset. And anti-NMDA receptor encephalitis is just one type of autoimmune encephalitis. So when we're talking about autoimmune encephalitis, it's classically divided into two groups. Group 1 describes the typical paraneoplastic encephalitis. So in this group, the antibodies themselves are not pathogenic. The immune responses are a result of the molecular mimicry between the neuronal tissue antigen and the tumor antigens. So those antibodies direct their activity intracellularly, so it amounts a T-cell mediated response. Group 2 is where anti-NMDA receptor encephalitis falls under. So in this group, the antibodies themselves are real pathogenic antibodies. So this is a B-cell mediated process. These pathogenic antibodies direct their activities against synaptic or cell surface antigens. So in this case, NMDA receptors are the target of these pathogenic antibodies. So since these are actual pathogenic antibodies, they can be removed by plasma exchange, which is one of the reasons why it's so treatable. So what are these pathogenic antibodies? I know this is all, like, we're not all super into this stuff, so I'll just go over the basics really quickly before we get to clinical presentation. These antibodies are IgG antibodies against the NR1 subunit of the NMDA receptor. So taking a look at a normal NMDA receptor, there's a magnesium plug that blocks the receptor. Once that's removed, the glutamate and glycine can bind to the receptor site. Channel opens, the receptor is activated, we have depolarization. So what happens in the anti-NMDA receptor encephalitis is that the IgG antibodies, as you can see on the right, bind to the subunit, the NR1 subunit of the receptor. So the actual receptor, the NMDA receptor, is actually internalized and becomes essentially non-functional, like non-existent, hypoactive. So why is this important? So by understanding this, we can hypothesize why anti-NMDA receptor encephalitis presents with psychiatric symptoms like psychosis. So just a really quick overview of dopamine pathways. Overactive mesolimbic dopamine neurons cause positive symptoms psychosis, so the hallucinations, delusions. And underactive mesocortical dopamine neurons cause a negative symptom psychosis, like the blunted affect, apathy, poverty of speech. So too much dopamine in mesolimbic pathway, positive symptoms. Too little dopamine in the mesocortical pathway, negative symptoms. So how can anti-NMDA receptor antibodies cause positive symptom psychosis? And again, I'll be really quick about this, just 2 slides on this. So on the left, we have the normal brain. So when NMDA receptors are activated on this interneuron then releases GABA, which then inhibits the dopamine release in the mesolimbic pathway. So that's like normal brain. So in the anti-NMDA receptor brain, as you can see in the 2 representations on the right, they're both representations of the anti-NMDR brain. So these NMDA receptors are essentially turned off, right, by the antibodies. So the neuron no longer releases the GABA. And so when there's no GABA released, the tonic inhibition of the mesolimbic dopamine is no longer there. So you end up with increased dopamine in the mesolimbic pathway, hence the increased positive symptoms. And how these autoantibodies can cause negative symptom psychosis is very similar, but just with a few extra steps in the pathway. So again, you start with the NMDA receptors being turned off. So now there's no GABA release. But here there's a secondary glutamate neuron that was before inhibited by the GABA and is now disinhibited or activated because there's no GABA. And then the secondary glutamate neuron now activates a secondary GABA neuron. So now there's an increase in GABA release, which inhibits dopamine in the mesocortical pathway. And so we're unable to supply the frontal cortex with adequate dopamine, hence the negative and cognitive symptoms of psychosis. And looking at the brain as a whole, there are 3 identifiable areas most affected by anti-NMDA receptor encephalitis: the dorsolateral prefrontal cortex. So here we get all the mood symptoms, the ventral tegmental area, as we discussed earlier, with the dopamine pathways resulting in psychotic symptoms, and the hippocampus, where we get more of those cognitive and memory deficits that we see. Okay, so now that we've seen it from a receptor and circuit level, how does all this translate clinically? So in the first week or so of this illness, we have what's called a prodromal phase. So headaches, mild fevers, and maybe some respiratory or GI symptoms. All in all, it looks a lot like a viral illness, like no big deal, right? 80% of the patients have these symptoms. Then about 2 weeks into the initial phase, you start to see the psychiatric symptoms, and this can be really variable. It can range from delusional thoughts, paranoid ideations, perceptual disturbances, anxiety, agitation, fear, disorganized behaviors and thoughts, cognitive deterioration. So short-term memory loss can be a presenting feature. You can also see speech abnormalities like echolalia, perseveration. And after that, you get into the neurologic complications, which often occurs weeks to months into it. So after the psychiatric manifestations. The most common thing you'll see are movement abnormalities. So oral facial dyskinesias, that is often the most common and a clue to the diagnosis. So if you see like grimacing or lip smacking, you want to pay attention to that. Chorioathetoid movements, so like the writhing, twitching, snake-like movements of the extremities, is often a good clue as well. Dystonic posturing is another one. And of course, seizures is a big one. I read a statistic that I found pretty shocking. It said that greater than 25% of new onset epilepsy in female patients between 18 and 45 is attributed to anti-NMDA receptor encephalitis. So that's, I felt like that was pretty substantial. And also around here, there's autonomic instability can occur at this stage as well. So after that, you move to the recovery and relapse phase. Some patients have a prolonged course of illness that can show spontaneous neurologic improvement. The cognitive and psychiatric functions are the slowest to improve. So generally, what happens with the recovery is it occurs in reverse order of the symptom presentation. So the psych symptoms actually resolve later than the neurologic symptoms. And not everyone recovers with treatment. Approximately 20 to 25% will relapse. And then you have the late phase, phase 4. So the majority of patients who make a full recovery on hospital discharge will still have some deficits in executive function, impulsivity, behavioral disturbance, sleep patterns, not to the degree that brought them to the hospital, but not completely back to baseline either. Here's another look at the symptom overview that groups the percentage of symptom presentation by age rather than timeline. So as you can see here, these symptoms we discussed, really do show up, right? Most patients don't just have 1 or 2 symptoms. It's clear that a lot of these symptoms are present. And of all of them, the most common are behavioral and cognitive symptoms. You can see it's nearly 100% across all age groups. So again, that's why we get to see these patients first a lot of times. So speaking of these highly variable psychiatric symptoms, what are they? The most common psychiatric presentations are delusions, aggressions, and mood disturbance, especially mania. That's a big one. The presentation differs between young children and teens and adults. So anti-NMDA receptor encephalitis has been documented in children as young as 8 months old. That's not the most common, obviously, but 8 months it's been shown. And how it presents in younger kids is a lot more subtle than older kids and adults. So in young kids, common symptoms are temper tantrums, hyperactivity, irritability, sleep dysfunction. So you can imagine the differential is quite broad if you just have these symptoms. And in the absence of other symptoms initially, you can see how they can be referred directly to a psychologist or a psychiatrist without seeing like neurology or anyone else. These symptoms tend to wax and wane, and about 3 to 4 weeks later, they morph into more classic psychiatric symptoms, and the neurologic symptoms we discussed earlier can start to show up. And of the neurologic symptoms, movement abnormalities and seizures, especially seizures, are the most common in young kids. In teens and adults, common initial symptoms are anxiety, insomnia, delusions, mania, paranoia, and these can often progress to alternating agitation and catatonia, which you saw with the journalist Susanna Collin. So we now learn the most common symptoms of anti-NMDA receptor encephalitis, but that's still pretty similar to a whole lot of primary psychiatric disorders, right? And we're just not in the business of ordering LPs across the board. So what we really want to know is if someone walks into our office or ED or whatever setting we're working in, what are the things we look for that clue us in that there may be something else going on? If we can distill everything we learned into red flags, what would they be? So first, red flag, autonomic disturbances. So tachycardia, fever, hypertension, hypoventilation. Like neurologic symptoms, so we talked about earlier. Oral facial dyskinesias, twitching, grimacing, lip smacking, those are big. Seizures, rapid progression to catatonia, that's big too. History of disorders. So as we said earlier, there's about a 25% chance of relapse. So if anti-NMDA receptor encephalitis has occurred before, your antenna should be up and you should be on high alert. Extrapyramidal side effects of antipsychotic agents. So now obviously this can occur with somebody without anti-NMDA receptor encephalitis, but studies have shown that those with this disorder are particularly susceptible to extrapyramidal side effects of antipsychotics. So if you have a patient who seems really sensitive to antipsychotics and has some of these other things going on, then your suspicion should be high. Another red flag, and this is a big one, is if there's a current or history of ovarian teratoma, small cell lung cancer, breast cancer, or thymoma. These are cancers strongly associated with anti-NMDA receptor encephalitis, especially ovarian teratoma. So anyone with new onset psychotic or manic symptoms with a history of any of these cancers should be tested for anti-NMDA receptor encephalitis. And on the flip side, if you have a confirmed case of anti-NMDA receptor encephalitis, you should be screened for these tumors, like our patient was in our case presentation. Another condition that's recently found to be correlated with anti-NMDA receptor encephalitis is herpes encephalitis. I think the correlation was about 20%. Herpes encephalitis can trigger the formation of NMDA receptor autoantibodies. So this can result in the onset of chorioathetosis, the writhing, twitching, snake-like movements of the limbs. And this occurs about 3 to 6 weeks after the herpes encephalopathy. Just a little bit more about the ovarian teratoma risk factor, because this is a big one. The exact statistic of this depends on what studies you look at. I've seen anywhere from 26 to 59%, but most sources say about 50% of the cases are associated with ovarian teratoma. Of note, children under the age of 18 are much less likely to have this association. The suggested mechanism in which this association works on a very, very basic level is that the antigen travels to a regional lymph node, and through the internal carotid artery, it then enters the brain. The antigen presenting cells then presents it to the memory B cells, and they produce these antibodies, and it's these pathogenic antibodies that attack the brain. So taking into consideration all the risk factors, symptoms, and red flags we talked about, the Australian New Zealand Journal of Psychiatry actually came out with a symptom list in which, if you meet this criteria, antibody testing should be ordered. So it's if you have a first episode of psychosis and any one of these following symptoms: concurrent neurologic symptoms, as we talked about before, severe cognitive involvement, catatonia or agitation, atypical heightened sensitivity to extrapyramidal side effects of antipsychotics, or the need for ECT because of illness severity. This is not to say that everyone who meets criteria for this has anti-NMDA receptor encephalitis. This is not a diagnostic criteria. All it's saying is if this criteria is met, then testing should be considered. So what do you need for diagnosis? As all of you probably inferred earlier, the gold standard is a positive antibody to NMDA receptor subunit in either the serum or CSF. Usually both are done. Now this can take some time, so in the meantime, other tests are usually done in an effort to narrow the differential. So as we said, CSF and serum antibodies, but also other things in the CSF are associated with anti-NMDA receptor encephalitis. About 75% have elevated white counts, usually lymphocytic predominance, and this is what we saw in our case presentation as well, but neutrophilic predominance can also be seen. About 10 to 15% have elevated protein. Brain MRI is usually done, which is surprisingly not very helpful, or unsurprisingly not very helpful. About 50% of the cases of the MRI will appear normal, which happened in our case. Most common abnormal finding is a non-specific T2 hyperintense lesions involving the gray and or white matter of the cortex, basal ganglia, or brainstem. So again, very non-specific. EEG is often ordered to evaluate for seizures. About 90% will have slowing of background frequencies, which is pretty, again, non-specific. But non-specific doesn't mean insignificant either, right? It just won't make or break a diagnosis. About 25 to 50% will have epileptic features, such as spike and wave discharges. A neurology consult is always wise. An infectious disease consult is also recommended. Anti-NMDA receptor encephalitis not only is associated with herpes encephalitis, it can also present very similarly. So evaluation for a viral encephalitis, particularly herpes, should always be done. And a tumor evaluation, as we said earlier, there is a strong correlation with specific tumors, always good to look for those. So what if we don't have antibody testing? The Lancet Neurology suggested this 3 criteria algorithm you can use to make a probable diagnosis of anti-NMDA receptor encephalitis in the absence of antibody testing. You can also make a diagnosis if you meet this criteria and have a systemic teratoma, but for a definite diagnosis, you should have antibody testing and it should be positive. As for the treatment, I won't go into much detail because, well, no one here will actually be doing this part of it, I don't think. But the takeaway is immunomodulating therapy and treat the underlying tumor if there is one. And now I'm going to hand the metaphoric microphone over to Dr. Graham to discuss the role of psychotropics in the treatment of anti-NMDA receptor encephalitis.
Thank you, Susan. So I wanted to just touch upon the role of psychotropic medication in patients who have anti-NMDA receptor encephalitis. I think other than the symptoms that Susan spoke about in terms of the consult setting, we often get called in regarding the severe behavioral agitation and aggression that these patients can display. And that's kind of pretty much been a theme in nearly all the patients that we have had at our hospital who have this diagnosis. It's more common in pediatric cases that they do become quite agitated and aggressive. And that could be a real barrier to actually getting the medical treatment that they need to treat their underlying illness, the immunomodulating therapy. And it can increase the risk of them harming other people and themselves. So it's really important to address. Second generation antipsychotic medication is the often go-to to help with the agitation and aggression, although the downside is that these patients are more susceptible to getting adverse effects of these antipsychotics, such as neuroleptic malignant syndrome and also EPS. And then that could be confused also with their underlying movement disorders from their encephalitis, as well as the autonomic instability that's seen in this encephalitis. Out of all of the second generation antipsychotic medications, Seroquel or quetiapine has been noted to have the fewest side effects. So that is a potential option. However, all of the many other second generation antipsychotic medications, including olanzapine, risperidone, and aripiprazole, have been reported in the literature to be used in anti-NMDA receptor encephalitis. And none of them have been shown to be more clinically superior than the others. It's just quetiapine has less side effects. Interestingly, the antipsychotics do not have any significant effect on treating the psychotic symptoms that are seen in anti-NMDA without concurrent immunotherapy being used. Even though these symptoms do seem like on the outside to mimic symptoms of schizophrenia, like paranoia, hallucinations, delusions, all of which our patient had. And other medicines that are not antipsychotic medication that can be used for behavioral agitation include clonidine, as well as benzodiazepines. Related to benzodiazepines, because some patients also have catatonia, the benzos can be helpful for that. Our patient did not develop catatonia. And then the other big area is insomnia, and we can use clonidine or melatonin to help with that. So that's it. Thank you.
Thank you, Dr. Graham. That was really great and informative. Thank you. So I just have a little bit more to go. So moving on to recovery, as we mentioned before, approximately 75% of patients have full recovery or mild deficits. 25% remain severely disabled, unfortunately, and there's about a 4% mortality. Recovery, as we said before, tends to occur in reverse order of symptom presentation. So the autonomic functions and dyskinesias stabilize first. So the neurologic, autonomic stuff usually gets corrected first, and the cognitive, behavioral, and memory problems take longer to resolve. Close supervision is recommended for several months for full physical and behavioral rehabilitation, and early therapy is associated with better outcomes. Okay, so we don't have a terrible amount of time left, but I would really like to use the last maybe 10 to 15 minutes to touch on something that I feel like is so important to this case and also to our field in general, and that is how to talk to families about psychiatric symptoms in the setting of an acute illness. And also, in this case, how to talk to a patient who is experiencing active psychosis. So first, talking to patients experiencing active psychosis. So first, letting the patient set the pace and style of interaction. So this is really important. A rule of thumb is to start by finding common ground for discussion before building up to specifics about their experience. But let them take the lead. If they hit the ground running, feel free to go there with them. If the conversation becomes too stressful or emotionally charged, you can take a break to allow yourself and the patient to calm down. Use a patient's terminology whenever possible. So, for example, patients often refer to their auditory hallucinations as thoughts rather than voices. Make sure you use thoughts in referencing these hallucinations throughout your interview. Also, it's important to use simple language and normalizing language. So using words like stress and worry instead of anxious. Keeping the language simple is especially important because often these patients' thought process is already pretty disorganized and they may have difficulty processing information. So you want to be as clear as possible when you talk to them. So keep your statements short, give one message at a time, don't give too many choices at once, repeat things when necessary, and avoid like complex language and metaphors. Sometimes patients with psychosis can be so disorganized that it's really hard to follow what they're trying to say. So if the details of what they're trying to say becomes unclear, that's okay. You can just focus on their feelings instead. That alone can help the patient feel understood without actually you understanding all the specifics of what they're saying. It can get kind of frustrating, actually, you know, if the person you're talking to is not responding back appropriately, and you're not sure if you're helping, but just know that even if the patient's having trouble communicating, your presence alone could be reassuring to them. So this isn't really important for psychosis patients, but don't say you understand completely what they're experiencing, because you don't, right? You don't have to agree or disagree or reason with the hallucinations or delusions. If they specifically ask you whether you experience these things, you can be honest and that this isn't what you experience, but acknowledge that what they are experiencing is very real to them and empathize with how they feel about it. So saying things like, that sounds really upsetting. I can see how that worries you. And it sounds like you don't know what to do. You know, things to try to just build that empathy and create empathy for that feeling rather than what they're actually experiencing hallucination-wise. If the patient has some insight and is questioning their perceptions and you build trust and you've demonstrated that you are open to discussion, they are open to discussion, you can gently discuss their interpretation. So you can say something like, how might that happen? Or you can ask them if there's anything they found that reduces their hallucinations or delusions. And there is, encourage them to use these strategies. So if they've developed like effective coping mechanisms, you can validate this and encourage this by just saying something as simple as, you've learned not to give these thoughts too much attention. Pay special attention to body language, minimizing signs of nervousness, distress, or anything that can be perceived as threatening. So that could be, you know, stop jiggling your legs, stop fidgeting, don't bite your nails. Especially if there's paranoia involved, which is often the case, this could be really distressing to a patient if they see you're nervous too. If the patient's sitting down, don't hover over them, don't stand over them. If the patient's suspicious and they're avoiding eye contact, you know, you should be really sensitive to this and just give them space. And as with every patient interview, but especially with a psychotic patient, listen carefully, reflect what you hear, ask clarifying questions to show that you're listening, and recap to make sure you've understood everything correctly. Much of the same principles applies to talking to families. First and foremost, always present appropriate information. Only what is true, no speculations. Use approachable language, explain to the level that's developmentally and age appropriate, depending on who the family member is. You want to offer opportunities for families to ask questions and share their feelings. So remember, these families have a lot of people coming to them every minute of every day, talking to them, we're talking at them, providing lots and lots of information. So giving them the space to air out their thoughts, feelings, and questions should be a priority, really with all medical professionals, but especially us as mental health professionals. You have to balance information giving, problem solving with validation. So remember, people cope with stress in different ways. You know, some people just want to get to the solution. Some people just need a little bit more time. But validation is always a good idea, no matter what the coping style is. It can be done with a lot of the same empathic listening principles we discussed earlier with speaking to patients. So reflective listening and just like lots of empathy. Oh, sorry, forgot to click. Provide pathways to care and support. So they may not be ready to discuss this in the beginning, but just always be ready with answers to where they can find care, medical care, mental health care, and also support groups and just other forms of support after this. Give them not only tangible resources, but know the pathways, so how they can get there. If this doesn't work, then they can try this. And if you're unsure, you can ask. Whether that is your attending, I had a great one, so that was helpful, or a colleague, or just like looking up online at resources. You know, these are tough cases, and it's completely normal to have to do some legwork to get it right. And then practice beforehand. This is pretty self-explanatory. Parents often ask how to help their child because this is such a foreign thing to them. You know, and it comes up so suddenly, they often don't have like enough time to like gather their wits and really think about what to do. And they may not have a chance to like really process this and like do research and do all that stuff. ACAP has some really good handouts to parents. This particular excerpt I got from a guide on how to help patients with children who are experiencing delirium. So kind of the very simple, very similar principles and like simple things. And to bring it full circle, I'd like to go back to the journalist Susanna Collin, whom we started this talk with. Here is a video describing her interaction with providers during her treatment process. And while you're watching this, I'd like everyone to think about how the situation could have been handled differently.
Sometimes, especially when a patient is difficult, and understandably to a certain extent, there is a kind of a wanting to dismiss them in a way, or dismiss their family. And I'm a perfect case of really listening helped me get that diagnosis. Now, when I was in the hospital and I received the diagnosis, a team of young medical students and I guess a physician came by, and they were explaining the disease to the group in my room. And my dad was sitting there next to me. And at one point, they said, just as an aside, she might have to have her ovaries removed. And this was the first time my father or I had ever heard this, because basically in some cases with this disease, there's a teratoma in the ovaries. And in some cases, they have removed ovaries in the past. So all of a sudden, we're hearing this as an aside from a room full of, young-faced, medical students. And my dad was so angry. It was the way in which it was delivered, as if we weren't even there. So that, to me, I know it's a very specific example, but just to be aware that, a reminder that we're, the human being going through a very traumatic, horrific experience. And, the more overly sensitive you can be in some respects, in some instances, is probably the better.
I cut it off. The better way is what she was saying. So, all right, that's all that I have. Any, comments on the video or any questions? Anything?
Thank you, Dr. Bates. Since we have, a fairly manageable group, feel free to unmute and ask your question. I don't see any in the chat right now.
It was just so thorough and comprehensive. I guess no one had any questions.
Well, I like to say it was, and it reminds me of a few things. Like, I feel like we need to go back to basics, remind ourselves that, good patient care is to talk to people with respect, right? And so not talking about the patient in front of the patient, and imagine that and regardless of how disorganized a patient may seem, that they could still hear and see you. The other piece that I really appreciate about your talk is also going back to your basics around diagnosing, right? So there is a rule out for all psychiatric diagnosis. Rule out a medical reason, right? Or a substance-induced reason, right? And so we really need to check off. It's usually, right, like your criterion D or E or whatever, right? It's at the bottom of the list. Make sure you've ruled out a medical explanation for these psychiatric symptoms. So I really appreciate that. Thank you.
Thank you for that, Dr. Stewart. I appreciate it. I think Ariel had a question about serum antibodies alone versus a CSF. So I did read up. That was a part of the presentation I cut out in the interest of time. But so there was a couple of studies that was kind of examining the difference between the accuracy of the serum versus the CSF, and while the serum antibodies are useful, they found that there could be a huge number of false positives as well as false negatives. So I think there was a specific case. It was a Wernicke's encephalopathy, and the serum came back positive with anti-NMDA antibodies, but the CSF didn't. So so that was a false positive, which is kind of interesting. So I think most cases the CSF antibodies are done in addition to the serum. And I think part of it is also, usually with encephalopathy, they have to do an LP and they have to do like the CSF analysis, for any bacterial or viral encephalitis anyway. So, the CSF is already drawn, but it's just a matter of sometimes sending out and getting the antibodies to come back.
Yeah, I'm just thinking about it in the outpatient setting versus the inpatient setting, if you're seeing a more mild presentation, because I think a lot of, similar to catatonia, we often miss these things in the outpatient setting because they're more mild. And so it sounds like they both have specificity and sensitivity problems, because otherwise, even if it was overly inclusive, it would help you at least push them towards a more thorough workup in the outpatient setting. And we're probably missing, I imagine we're missing cases in the outpatient setting. Yeah. I'm not as worried about it on the inpatient setting.
Yeah, that's a more thorough workup anyway.
Yeah,
that's a good point. Yeah.
There's another question about is there a specific neurocognitive profile that would raise a red flag for this condition that we should be aware of?
So in terms of like specific like cognitive symptoms, or so like the big cognitive symptoms, and sometimes this is like a presenting feature, is short-term memory loss. That is one of the big red flags. There's, all the psychiatric stuff we mentioned, and also just neurologic stuff, like the oral facial dyskinesia, so grimacing, lip smacking, that's really big, and seizures, and is that what you're asking? Or are you talking more just like the cognitive side of things?
Also, yeah, cognitive, like, is there like a pattern in terms of cognitive abilities that are, significantly diminished or atypical for a given person or individual? So you mentioned like short-term memory, executive function. Is there like a specific pattern, if you will, that we see with these folks?
That's a good question. I didn't come across any when I was, anything that's mentioned specifics of that. Dr. Graham, do you know of any other than like just memory loss?
No, just the memory. I don't know what would be picked up like maybe a year later after the person was more stable. And I would say while they're in the hospital, they're not stable enough to do any neuropsych testing because they're usually just disorganized and or agitated, and they wouldn't participate in it.
Yeah, it would be interesting. The neuropsych testing on the patient is ongoing right now, and I'd like to go back and look at the report to see what it is when it's done. But yeah, the main thing that, from what I read and from what I've seen in the case is this short-term memory loss. And it's interesting because like usually the patient presents, on paper it looks like a delirium patient, but it looks so different. It just looked like a dementia patient with short-term memory loss, almost like this in like 50 First Dates or something. I don't know. It made me think of that. Like at the end, you have those people who just like forget instantaneously what is going on.
Yeah, I've assessed individuals with Alzheimer and have sort of observed that where one will say something like, "Is that your water bottle?" And then 3 seconds later, "Is that your water bottle?" Very interesting.
I've actually evaluated a few pediatric patients in sort of like the interim cognitive status portion back on fellowship, and the common neuropsych pattern that I saw was, like you're mentioning, really bad memory that's pretty global across both verbal and visual and is not helped by recognition, as well as most of the patients I saw had pretty significant aphasia, so lots of language deficits. That were, again, pretty global, both receptive and expressive. And just kind of like slow was the third thing. So some slowed processing speed as well.
Thank you.
I see another question. Once a case is confirmed and being treated inpatient, what are some complications or side effects to watch out for? You mean side effects to the antipsychotic use, or like the immunomodulating treatment? Or just like what can happen after the treatment is started?
Who asked the question? Are you?
So it was a private question.
Yeah, it's not on my chat, so.
Michelle Siegel.
Okay, they may have had to step out. We're close to the 1 o'clock hour.
Yeah.
I have a question about family interventions. Is that, so, and this also depends on the rate of recovery and how do we, so I worry about those families who continue to have family members with this course of illness and with these extensive psychiatric symptoms. Do the kind of the same family interventions apply that we would use with, say, someone with a psychotic disorder diagnosis? Like, what's your opinion around that?
Oh, that's a really good question. So like on an outpatient basis, like after all this stuff is done.
Or supportive interventions for families. I just think of like NAMI, you know, for, you know, is that relevant to these families? Would that be?
I would say so, because I mean, and Dr. Graham, correct me if I'm wrong, like if you had other ideas about this, because they present so much like a psychiatric symptom, even though the neuropathology may be a little bit different, but I'm sure the family experience is the exact same things that a family of like a patient going through psychosis, you know, would experience. So I'd imagine the same supports would apply.
Yeah, I agree. I think just, you know, advising the family, obviously, that this would be, we expect them to recover. So it would be short term, but there was questions also with this patient before he left the hospital about the school setting, because there was like a lot of concern how he was going to go back to school or what he could and couldn't do. So I think, yeah, definitely a lot of support in helping the family to navigate.
Thank you. It is 1:01. So thank you for your time, everyone. What a great community. I'm so enjoying this series. So thank you to each of you, particularly to Dr. Bates and Dr. Graham. I learned a lot today, so thank you very much. Everyone stay safe and be well. Happy holidays.
Bye.